Thank you all so much for joining Devex and Philips today for Going Digital, Creating Enabling Ecosystems for Health. Today, we're going to go beyond talking about the power and potential of individual health tools. I think we're all well aware of that, and it's part of what brings us here today. But we're going to discuss what does health mean in a digital age. In fact, I was speaking with one of our panelists this morning, and he sort of helped me think about this reframing that we talk about digital health and throw around this term, but it's really, we're in a digital age, so what does health look like? And how do we bring the potential of these new tools to people around the world who currently don't have access? So this means we'll be taking a systems approach to ensure that more of the world benefits from these technologies, and we'll be bringing perspectives from government, the private sector, and the community of donors and NGOs to the stage here today. So I'm Catherine Cheney, and I'm a senior reporter for Devex. I focus on the role of the West Coast in global development, and I'll be facilitating the conversation today. I'm based in the San Francisco Bay Area, where researchers, investors, and technologists are working on many of the digital health solutions that are driving so much excitement. But as you all know and have probably struggled with, these are well-intentioned efforts, but they run into major challenges when it comes to scale, interoperability, and sustainability. So I look forward to learning from our panelists today about how we can ensure these fragmented efforts can be more streamlined and bring those lessons back to Silicon Valley. And similarly, I hope that each of you, in the midst of this busy ONGO week, can be present with us for the next 2 hours and think about what you can do differently walking out of this room. What's one thing you can do to actually help digital health deliver on its potential for UHC? So we all know that digital health technology has this amazing potential to reduce costs and expand access, and yet, despite growing attention and support, the majority of pilots still fail to scale, whether they come from Silicon Valley or elsewhere. This has to do not so much with the technology itself, but rather the ecosystem challenges, which we'll be talking about today, such as a shortage of qualified health professionals, weak regulatory frameworks, and limited infrastructure. You all know about this growing interest. Examples include the 2018 Digital Health Resolution at the World Health Assembly, the prioritization of digital health in the recent World Health Organization restructuring, which we'll hear about from one of our panelists, and of course, the meeting here at the UN General Assembly on universal health coverage. But in order to deliver on these goals around the digitization of health, we need a community of practice that shares lessons and commits to actions, which is exactly how we designed this event. Each of you are in this room for a reason, and we hope that you'll do something differently as you walk out of this room. So we'll discuss what more is needed to ensure that digital tools drive real progress on universal health coverage, and also what strategies work when it comes to the digital transformation of health systems. We'll have a perspective from the Ministry of Health here on stage, and I know we have several perspectives from Ministries of Health in the audience, which we look forward to drawing on. We want to hear from all of you in the room, so please be ready to jump in during the Q&A portion of our conversation today. And I want to make sure to focus the conversation at the outset. So when we talk about what health means in a digital age, we could go in many directions, and I know you all are working on many aspects of digital health, but today we're going to talk about the patient, keeping the patient in mind. So I want each of you to picture a patient and what all of this talk means for an individual who currently is not benefiting from digital technology and all it could bring to health, but might benefit with the right ecosystem, with the right digital strategies in place. So let's keep patients in mind. Let's keep in mind what this means for them, and let's focus on the digitization of service delivery, just to sort of make sure we have a clear focus in this very big space of what health means in a digital age. So before I invite our panelists to the stage, I want to take you all on a quick journey. I think we have a video queued up to play for you all. And speaking of putting patients at the center of our thinking, we'll be zooming in on what it looks like to create an enabling ecosystem for digital health to deliver on universal health coverage. So Devex visited Kigali, Rwanda as part of our partnership with Philips, exploring how one digital health solution, which you'll see is a small handheld point-of-care ultrasound machine, could be a diagnostic lifeline if rolled out in more rural and remote areas. And a critical takeaway, as you'll see, speaking of the enabling environment, is not just the importance of the technology itself, but increasing local capacity. And we'll learn about a mentorship program that does that. So let's cue up this video. and hopefully the sound as well.
Critical care at the same time as the ultrasound mentorship program coordinator here at Sehashika. Not too many people has been training on point care of ultrasound, and therefore we have limited resources, human resources to train other residents. The mentors program is focusing on mentoring local residents using international faculty.
I'm Dr. Trish Henwood. I'm the president and co-founder of PURE, which is Point of Care Ultrasound in Resource-Limited Environments. I'm also the director of global health in the Department of Emergency Medicine at Jefferson University in Philadelphia. PURE was founded in 2011, and we've been working on global ultrasound training and research programs, mainly in sub-Saharan Africa over the last several years. The goal is really to try to help increase local capacity and sustainably develop ultrasound leaders locally in Rwanda, and that's really the idea of this tele-ultrasound mentorship program that we're working on.
Initially, I got 2 months intensive training with PURE, where the faculty were coming to train us, and then after that, it's all about self-practicing during patient care. Not everyone who is trained on a point-of-care ultrasound can become confident on teaching it. Having this program has helped us to establish a quality assurance of the scannings of our mentees, which are the residents.
It's unique, I think, the idea of combining this essentially hyper-portable device that we can connect to Wi-Fi and use directly off of the tablet, in addition to having the React platform, so that can help us with some of this tele-ultrasound teaching that we're trying to do, so we can actually get our mentors and mentees better connected.
When you have a case, you go to the platform called the React, whereby you check who is online, and you can check with them if they are ready to answer your questions.
I just want to check you have a time to discuss a cardiac ultrasound.
For sure, let's chat. What's up?
The ability to incorporate ultrasound at the point of care helps buffer the capacity of the emergency medicine residency. And really, emergency care systems are a fundamental component of universal health coverage. They're how a lot of patients globally actually access care and access the health system. And so it's really important to make sure that that care is high quality at the outset.
The role of ultrasound in improving emergency medicine in Rwanda is really huge, because we have a limited radiologists, and sometimes the patient would have some delay of care without point-of-care ultrasound. Nowadays, I can make most of the diagnosis myself, which is my responsibility as an emergency physician.
To get us in the right mindset, as I mentioned earlier, ultimately, this is what it means for patients. So for digital health to really deliver on universal health care, we need to talk about the enabling environment, we need to talk about digital strategies, but let's keep patients and what outcomes for patients can be enabled by the shift front and center in our thinking. So before we bring the panelists to the stage, I want to go ahead and invite my colleague, Alan Robbins, co-founder, executive vice president, and head of global partnerships at Devex, to the stage to share findings from a report Devex produced in partnership with Philips. Alan?
So I can't quite see, is the, okay, it is up there. Well, so in addition to a great conversation today that Catherine will lead, we also are using this as an opportunity to launch a report that we did on, on global, on going digital, and it's looking at e-health systems. I just dropped it, and I don't want to embarrass myself to get it, but there's a flyer that you all have that has a link to the report that you can use to, you can download it. Fully encourage it today. Oh, thank you. Today is the launch day of that. So what we wanted to do is, so what I'm going to do now in this very brief time is to go over some of the key findings. You know, we at Devex, we do these sorts of reports regularly. You know, and what we aim to do with them is to really add new sort of conversation and sort of thought leadership to the space. And you know, in addition, I think we're fairly smart people and we can write good reports, but the real value add that we bring to it is from speaking to the experts. And that's what we're doing here. So for this report, we spoke to sort of the really juicy bits. We spoke to several dozen sort of top e-health professionals around the world looking at this. So briefly, we have 7 key findings for this report. Sorry, I'm sort of got my various papers here. So the first one, and again, this is what people told us. This is not our own sort of genius thoughts. These are what these several dozen experts told us. One thing that we need to look at is develop capacity and technical know-how amongst stakeholders, including government partners. So, basically, sort of one way to distill this is that technology really isn't the issue that we're looking at here. I mean, having good technology is critical to it. But what we do have isn't really being used to its capabilities. When you look at it, like having enough money is important, but it's not really the most critical issue. And in this area, it's about stakeholder understanding and really about technical know-how as well. So second key finding that we have is, build an inclusive approach to stakeholder management and align key initiatives. And again, I'll sort of drill down to this, basically looking at that alignment is critical. So sometimes you have, a community might decide one thing, but there's a technology that's available and it's really good that's for another. And just making sure that that is minimized and that we have, as often as possible, if a community has a need, that we go to them with a way to address that need. Not with sort of looking at, say, a diabetes solution when the community's main issue is, say, a maternal health need. So aligning those initiatives. The third one here, establish reliable physical infrastructure and data standards to generate and share meaningful health information. This gets down to everything from having roads, that connect the communities to one another, having good internet connections, having consistent ways of inputting information to systems. All of those, if you want to build investment in e-health, we need to make sure we're talking about these things as well. 4 is build demand for digital health services and tools. This is looking within the communities themselves and looking at the leaders within those communities, looking at advocacy and other sort of just awareness raising for these issues. 5, and sorry I'm going through these relatively quickly, but there will be a lot more conversation about them later on. Community and human-centered design drives digital health product sustainability. So basically, health systems providers, they need to understand each community is different and they need to be part of the solution. Sometimes it's assumed, I don't think in this group, I think this group is a fairly sophisticated group, but sometimes it's assumed because a technology worked well in one place, it's going to work well in another place, and making sure we don't go in with those assumptions. 6, develop technology solutions that are user-focused, user-friendly, and adjust to the local context. So looking about local community needs, looking at the individual, in addition to the communities, look at the individual end user, looking at sort of the customer, what do they need? If you think about when we talk about communities and countries or whatever sort of big unit of people, obviously it's all made up of these individuals and these individual consumers, as it might be in this case. When you drill down to looking at what is the individual need, you kind of come to a realization that the simpler the better. That something is easy to use, whether it's an individual sort of recipient or an individual healthcare provider, the easier solution is oftentimes the better solution. And finally, which is something that I'm sure won't surprise anyone here, focus on training and workforce development to increase adoption. This is probably nothing new. We all know that the world has so many, it's not just in e-health, it's in all sorts of technologies, so many e-health solutions that just are not being used because people don't know how to use them. So that training, that workforce development is absolutely critical. So I think with that, I will just move on. I do very much hope that everyone downloads the report today. If you're looking at your phone during any point in this meeting, I'll assume that's what you're doing. I think everyone will. So we can, and then I will bring Catherine back, and she can help introduce the panel.
All right, so let's dive in. This next panel will be going deeper into many of the elements you just heard about from that report. We're going to be talking about enabling environments for digital health before we move into what effective digital strategies look like. So I'll go ahead and welcome our panelists to the stage, and then I'll be joining them. First, Dr. Jan Kimpen, Chief Medical Officer at Philips. And next to him, Elaine Koch, Deputy Assistant Administrator for the Global Health Bureau at USAID. And I see over here Steve Davis, CEO at PATH, which many of you know is an NGO based in Seattle focused on global health innovation. So I'm quite focused on their work as our West Coast reporter. And finally, Bernardo Mariano Jr. from the World Health Organization, where he is the Chief Information Officer and can talk with us about their digital health transformation. Again, for each of our panelists, wanting to bring it back to what does the digitization of service delivery mean for patients? Thank you. And I'll come join you. Right in. And again, would encourage our audience to think about questions you have, and we want to hear your personal experience dealing with these challenges around digital health and UHC. So we'll bring the mic to you in a moment. But first, I want to actually direct a question to Bernardo, who's directly to my right. So your role is to ensure that the World Health Organization is advancing its digital capabilities to deliver your goals more effectively. I want to specifically ask, bringing it back to patients, how will patients benefit from the digitization of healthcare?
Thank you. When the Director General of WHO created the Department of Digital Health and Innovation, one thing he said that I would like to share with you. He told me that this team is the team that will define the future of WHO. The future of WHO in the digital ecosystem. And to answer the question about how the work that the 11,000 WHO staff does to improve health in the world, both on accessibility, affordability, and universal health coverage, we want to make sure that the digital presence of WHO reaches everyone. And today, our guidelines are designed to speak to or interact with ministers of health. We have to change that to make sure that it reaches consumers, people, patients, and just to ensure that we really deliver the health for all. Of course, that needs a strong partnership because half of the world is still not connected by broadband. So we need to bear in mind that. On the other hand, also, there are other challenges such as the fact that the healthcare industry and the tech industry, they have two very different mode operandus. One very aggressive and very used to change and innovation, and the other one much more conservative and used to quality and care and assurance of that quality. So how can we ensure, as WHO, how we can ensure that both the regulators, the government, but also the private sector, as we deliver digital health solutions, we increase quality, we reduce costs, we increase accessibility. So those are the key areas that we want to make sure that in addition to driving revenue from the private sector, we understand that drive, but we want to make sure that health outcomes are not penalized.
Mm-hmm. I'd love to come back to you in a moment once we hear from our other panelists on exactly how you bridge that cultural divide between the tech community and the healthcare community. So we'll come back to that. So Steve, I know you all at PATH have been working closely with WHO on some of its work on digital health, but PATH also has a long history of working in this space, and I think you have a lot of insight into why certain projects fail or succeed. So specifically, when it comes to this problem we articulated earlier of pilots that never make it to scale in the digital health space, can you talk us through why, and maybe some examples you've seen of what it really takes for a pilot to go to scale?
Yeah, so first of all, thank you for organizing this, and I do think this is one of the most exciting frontiers in global health today. And I guess I'm kind of talk about your first question first. I actually come out of the technology industry, was an early internet guy, and I think one of the things that I'm probably my West Coast guy represent that aggressive side of the tech industry. Sorry, but I do think the thing that I learned early on in this work is the tools of digital and data enable you to obsess on the customer in a way that's extraordinary. You can understand them, find out, learn, engage, change the tool tomorrow to tweak it, to make it more relevant for the next customer. And that obsession is amazing. I mean, we now have our offices in Seattle or happen to be in the middle of the Amazon campus, which I could spend an hour talking about how weird that is. But on the other hand, it is fun to sit on the elevator once in a while and listen to these young engineers obsessing on something to improve that button tomorrow. And I love that in the sense that if we take that same approach to the patient, whether it's a patient in a clinic, a patient at home doing self-care, or a patient, in a tertiary or secondary system, that actually is going to change the game, which I don't think we often take a terribly patient-centered view in a lot of the interventions that we have created in global health, particularly because we have been such a supply-side driven global health community. So I think taking this, shifting to a demand side, getting the patient. And then, of course, the challenge is we have, we're kind of this sort of crazy cowboy land. Everybody's out there doing their thing. There are lots and lots of pilots. There's lots and lots of interest. There's lots and lots of, and that's not altogether bad, right? That's sort of a natural evolution of an industry, and there's a certain sort of rationalization that starts occurring, and I think we're getting to that rationalization moment. But we do need to now go from those pilots to scale. And, there are 3 or 4 key principles then. How do we actually ensure that this fits within the national or subnational health strategy, which, I think has to be a cornerstone of scaling up anything. Does this actually, does this sync up with what the government or even if it's a private sector intervention, how it fits into that government model? The second, interoperability is critical. Part of the problem, we really don't have a lot of tools to talk to each other yet. And it's such the essence of digital and data capability is it has to actually enable and leverage each other. And so we've got to work on that. Third is clearly simplicity and harmonization. So, when we look at things where we've created a lot of bells and whistles, and yet it doesn't really get the fundamental job done, and then making sure that we can do more than one thing with one tool. So one of the things that we've really got to break the code on is having these community health workers that are carrying 5 or 6 different mobile devices because different funders or different programs have given them, do test this with this one and test. That's just, it's expensive, it's wasteful, it's complicated, but it's actually ludicrous given the nature of the ability to have an integrated model.
And quickly, I'll say on that, back to patients, that it doesn't lead to great outcomes for patients.
Exactly. And then the other one, just finally, I have a lot of thoughts on what we need to do for enable environment, but the final one, I think we should all be obsessing a little bit more. Even this week, I've noticed how infrequently we're talking about self-care. This isn't just enabling a health worker, and by the way, remember a lot of places, at least Passman's this time, doesn't have a lot of health workers. And we obviously are committed to building up that capacity, but there's also the opportunity to actually put more and more great capabilities right into the hands of a mother or father or a patient. And some of that opportunity, and it is happening inevitably, but that opportunity is one that we need to kind of almost over-index on, because it's going to take a sort of a mental shift for this industry, which is still fairly clinic and professional focused, to get to the comfort level of saying it's okay for, you know, a parent can track with a digital, a connected thermometer to be tracking, you know, larger trends around your family's health. That's exactly what we need and want in the future.
Yeah, absolutely. Great point. And I think a lot of what we'll be talking about today, while the focus is on digital health, it's really about incentives, mental shifts, partnerships. It's really about people and how we make some changes. So, Iraine, I wanted to ask you, Steve mentioned bells and whistles, and I know that USAID is really excited about the potential of digital health tools, but can you talk specifically about investments you're making in the enabling ecosystems so that those tools are more than just bells and whistles, but actually deliver outcomes for patients?
No, thanks very much for that. And I would echo Steve's thanks for organizing this and this conversation. This really is an exciting area, and I think hopefully does have the potential to change that mindset, as we've been talking about. So USAID spent, you know, for as long as we've worked in global health, you know, we work on issues about building country-level capacity to manage health issues, and lots and lots of information, lots of health information systems. So that's been core to how we work with countries, whether it be in the public sector, private sector, et cetera. So the digital technologies are extraordinarily exciting to that, but there is the risk, as Steve said, of the wild, wild west, right? That, you know, you have this, you know, everybody's jumping in with their own system. So one of the things we've done is work very closely with WHO through the Health Data Collaborative, but also with other donors on a donor strategy for digital health. In part with the sort of the fundamental core of that is helping countries develop a strategy for using what digital technology they're going to use, so you don't have the health worker with 5 phones having to walk around and respond to everything, to move away from that kind of a system. But is there a system or 1 or 2 systems that really does reach what is the needs of the patient and the system to address the health issues? The interoperability issue, I think, is a huge one, and one that I think really needs to figure out the technology to get over that, so you can have one system talking to another, and that the data is ultimately owned by the individual, but that it's accessible to the clinician. So that strategy has also been something that we've taken back with USAID in line with those donor principles of how we work with countries, how we work with each other. So it's not the wild, wild west, but at least you have some coordination and not multiple streams of technology trying to get the same kind of information back, but using it in a much more coordinated, strategic, thoughtful fashion without slowing it down, right? This is the issue. Coming from the East Coast government side is rather different from that West Coast, you know, technology hub. That said, there is a real value from the looking for ways that we don't duplicate, we don't confuse, and we don't have multiple streams of things going. The other piece I would say is, you know, looking at, you know, critically important in addition to health capacity, you know, core to what we do at USAID is all about helping countries. Our administrator talks about the journey to self-reliance, and of course technology and digital technology and the use of that in a way is absolutely core to those principles. But at the same time, we're working in countries where infrastructure issues are huge, right? You know, you don't always have connectivity. You don't have running water in every health facility or electricity, right? So having the technology is absolutely hugely helpful, but at the same time, there are some really, really fundamental issues that we collectively need to figure out how we get on top of. And the last piece is keeping that patients in mind. Across the health portfolio, we talk a lot about that patient-centered care and really making sure that programs are moving in that direction. And I think that's where digital technology could have a huge, huge impact on really turning that around in a way of getting away from the very traditional supply side approach to healthcare, of really putting it back in the hands of the patient.
Great, thank you. And I want to come back to picking up on a few themes I've heard. You know, Bernardo mentioned broadband being a challenge, and you mentioned running water, electricity. So I really hope in our conversation we can talk about the infrastructure challenges that extend beyond what the global health community is typically focused on and how you build those partnerships, but we'll get back to that. So Jan, in preparing for this panel, I read something you wrote for the World Economic Forum And you said, the framing is, here's how to make value-based healthcare a reality. You said, day by day, the healthcare community is collaborating to transition away from siloed and wasteful care delivery to more patient-centric and productive healthcare. And yet, I think that shift is happening faster in some places than in others. So can you just talk about how do we make that a reality, specifically in low-income countries, low and middle-income countries, which is our focus today?
Thank you, Catherine. I want you to take one moment and think about your 40-year-old brother or your husband or your friend who has pain on his chest. Probably that is the first time in his life that he will enter the healthcare system, which is basically a sick care system and not a healthcare system. The journey that he will be embarking on will be discontinuous and fragmented. That's the first thing. Second thing, the journey that he will be embarking on will be one that is a doctor-centered journey, not a patient-centered journey. He will be welcome to a doctor if the doctor has time, not when he needs him immediately. Third is, it will be quite expensive because the whole healthcare system is built on the physical face-to-face encounter between a doctor and a patient. And third, if he lives or happens to live in an area of the industrialized world where he is remote from the first healthcare facility or in lower income countries, he will not even reach a doctor. That is how we are organizing the healthcare at this point in time. It is also paid like that. It's a volume play. That is unsustainable. And digitalization can help us move from this very doctor-centric, fragmented, expensive, volume-driven system into a value-driven system that is concerned about your outcome, concerned about your experience as a patient, concerned about the experience of your doctor, and concerned about the costs that have to come down. Now, take all the digital solutions that we have, and imagine again your brother with pain on his chest. He can, now when he goes into the healthcare system, all his data will be shared seamlessly between all the healthcare professionals in that system. So he will not go into a fragmented and discontinuous journey. He will move into a seamlessly organized, continuous journey. Second, by using digital apps, he will be in the driver's seat. And once he gets out of the hospital, he can manage his own health preventively when he is back at home. If he is living in a remote area, he doesn't even have to go to a doctor. He can stream his data to a remote center where the diagnosis can be made and the treatment can be started. And finally, he will probably not have to meet in the future a doctor really face-to-face because telehealth will make it possible to deliver remote care, and doctors will also reimburse from this remote care. So by using all the digital solutions we have, we can turn a very patient-unfriendly journey through the sick care system into a patient-centered journey in a healthcare system.
I love that framing. And what I'd like to ask any of you to jump in on, so we were just taken through this journey of a patient-unfriendly sick care system to a patient-centered healthcare system, which I think is the goal, what we want to talk about today. What is a specific example, because I think it helps to have exemplars, success stories, positive deviance from low and middle income countries that we can point to and say, that's what needs to be replicated. So can you tell me about a specific example you're excited about where patients have gone through this journey in a low and middle income country context? Go for it.
Can I continue? We work together with NGOs in low and middle income countries, for example in Africa, where we have put together what we call community life centers. And that's started as a container with some tools there, but it has gone into a digital world, where people that are very remote from the usual healthcare systems and have to travel a long distance to high-level hospitals are cared very closely to home by making use of connected devices, of treatment at home, of preventive actions at home. And we do that in Kenya, we do that in the Republic of Congo, we do it in South Africa and in Ethiopia, where we have these centers in the rural areas where patients that have the first signs of disease or that have to be monitored because they are pregnant or that have to be helped with raising a child that is just born are flocking to a very local, very basic primary care center and are only referred to a secondary or tertiary center if they really need it.
And I think, I know one of our panelists in the second panel can speak to how technology, AI, for example, can help reduce the burden in these emergency rooms that are filled with patients who don't necessarily need to be there. Either of you want to jump in on the success stories?
Yeah, another example is in Indonesia, where we have partnered with the government and private sector on reducing maternal mortality, because maternal mortality had been quite high. But what was happening is women would present at healthcare facilities and not get the care they needed right away. And there's not a whole lot of time when you're in the middle of a complication or in labor. So setting up a system which is using cell phone technology and a call-in number, the person who saw that woman first could call ahead to the referral facility with all of the right information about what was happening with that patient, so that by the time she got that, the facility was absolutely ready for her immediately with all of the medical detail, all of the medical information, whether it be blood type, what's happening with her, heart rate, all those kinds of things. So it was a way to really cut down those deadly delays that happen within the system, and having a single call-in number and a system that could really connect, whether it be the midwives, the healthcare worker, the local facility, private sector, et cetera, with the hospital.
But on deadly delays.
Yeah, I mean, I think there's some really great examples across the board of where we're seeing sort of that patient-centered model. The one that comes to mind that is a bit different than those two examples is the work that a number of groups are doing along with various governments on the drive toward a malaria control, but elimination in countries, and taking a very explicit patient data-centered approach. We've created this project called Visualize No Malaria, but now very deeply embedded in the government of Zambia's effort to eliminate in other number of countries, where it really starts with what do we know through not at the clinical level, but if there's an outbreak where a community health worker knows what's happening at a household level, then doing a variety of mapping and using even sort of some data models that you can figure out where the likely infection of the parasite might have traveled, and then you start doing a set of follow-on testing or treatment, and then layering that with light touch machine learning, so you can start integrating meteorological data with patient data and epidemiological data, and now we can even go after the hotspots. And it's been an interesting, we've seen in some parts of that country 95% reduction in mortality from malaria through 4 years of that kind of concentrated effort, and now it's scaling up. But what's really interesting is it's really very private sector driven too. We've pulled together 8 different private sector companies, Twilio, Box, Tableau, and really it's the exemplar there is the stack of technology. So you've got to, it's not just, SMS, it's SMS for nudging, but it's also who's going to do the data visualization and how does that work with the ministerial level. And then you have to layer it on in terms of the various kind of consumer data-driven technology. So I think the exemplar there is we've got to stack these tools together rather than do one-offs.
Quick question on that. So you mentioned Twilio, Box, Tableau. One of the challenges I want to make sure to get to is you have tech companies who have so much to bring to global health, and yet they don't tend to know how to work with governments and ministries of health. But this is a positive deviant, if you will, right? I'm guessing a big part of that is past involvement, but can you speak to what is the replicable strategy here of this being a rare case where these tech companies, together with PATH, are working with the Ministry of Health, several ministries of health on this goal?
Well, first of all, I would never start with you don't work well with government. I think it's and second, another thing, I think what we're finding often is not always. We have good, interesting projects going with Amazon and Facebook and Google and others, but that you sometimes the very big companies is more complex to manage. So sometimes there's more opportunity for sort of mid-sized companies. But the third is it's sort of like lead with what's most interesting. So we've done a lot of work on corporate engagement, and this is true in tech or other places. But you know, there's various tools. There's sort of this one-size-fits-all mentality sometimes when the NGO sector or the public sector work with corporates, and it's like, wait a minute, there's like all these different types of engagement, whether it's philanthropic, whether it's discounts, whether it's you know, CSR type stuff, whether it's shared value, business development, whether it's employee engagement, and you need to kind of put that portfolio of tools together and to figure out. So one of the things we've certainly found in the high-tech industry is that rather than going and saying, we have a project, would you help us? And certainly not going and saying, we have a project, would you fund us? But the main thing is, we have a problem, will you help us solve it? And that has changed the way they have interacted with us.
That's really helpful. And no, I totally agree. There are success stories of tech companies working in partnership with governments, and I think it's about learning what are those replicable strategies. So that was super helpful. I know you wanted to jump in here, and you bring a unique perspective from the WHO purview on what does and doesn't work in success stories. So I'd love to hear your thoughts.
Thank you. Let me maybe start by asking my favorite question, and from Novartis Foundation knows. How many government officials are sitting in this room? Can I see your hand? Okay. What do you call it? 0.1%? I mean, when you talk about partnership, it starts with ensuring that when we are gathering in venues such as this one or the others, we have a good mix of representation from private sector, public sector, UN, and government. It is true that when the WHO organizes a meeting, the number of hands you saw from government will be equivalent to the number of hands you will see from the private sector in those meetings. Mm-hmm. So we need to do better at that, starting from there, because that's what will make a difference. We are working, at WHO based on our member states' resolution from last year to develop and have approved a global digital health strategy. I think some of the examples that the panelist members here outlined requires scale up, requires perhaps governments to share how did they prioritize those digital health investments.
Yeah.
Because prioritization of digital health investment will make a difference, because otherwise we get into a pilot type, as we call it, pilots that do not scale up. But WHO also understanding that we have a different mindset compared to perhaps the mindset from the private sector. We are bringing together a digital health technical advisory group. We have one member here actually that would, and Steve Davis will be the co-chair of that, to ensure that the mix of private, academia, public sector, they really sit down and discuss and try to address some fundamental issues. Let me tell you two of them, and there are many. I think one of the panelists mentioned interoperability. Mm-hmm. That is a problem every country has. From Japan to US, you name it. How can we solve that problem? How can the tech industry innovate to bring interoperability in the health sector? The other area that I would like to outline here is data governance. Mm-hmm. The AI tools, AI leans on algorithm, computing power, and data. So how can we ensure that an AI-supported device that is diagnosing a disease of somebody sitting in Maputo, I'm from Mozambique, so I can talk about my country without offending anyone, is sitting in a very remote area in Mozambique, the data that tool is leaning into to make the decision about that disease includes some localization, some local data. So how can we then ensure governance of that data across? We've been toying with some idea, toying with an idea that discussing with some member states about perhaps an international Bill of Rights on health data to really ensure that we demonetize the data, because data is being monetized heavily now. We make it part of global goods. So those are some of the areas that we as a WHO, with our convening power, we are bringing member states, private sector, academia to really address some of these fundamental issues.
Thanks, Bernardo. And you really set us up nicely for the next panel. Because note to self, I want to make sure we talk about, when it comes to designing health strategies, how do we prioritize, how do we ensure interoperability, and what about data governance? And I look forward to following this potential international Bill of Rights on health data. That sounds fascinating. I want to go ahead and open it up to the audience, so please, if you have a question, get them ready. And I want to start by actually bringing Nicole Speaker into this conversation. So she and I had a conversation ahead of the panel where she said her question has to do with patients at the center. And as I mentioned, I do want to gear our conversation toward that. So Nicole, any thoughts to share or question for the panelists?
Great, many thanks, and good morning, everyone. Really excited to be here today. Yeah, I actually wanted to bring in the discussion on patient-centeredness, but an angle that I haven't heard any of the panelists talk about yet. And if you think about why we are all here and why do we think digital is going to be so transformative in UHC, I want to take an example of how I got here. I live in Nairobi. I got here by taking an Uber to the airport, get on a KQ flight, 15 hours. It was a bit of a challenge. And then I took an Uber to get to this place. And all of this was triggered with my mobile phone. In 2 cities that I don't come from, I was able to open an app, get into a car with a person I did not know, no taxi service in between, and I could see on my mobile phone where I needed to go. So even though I didn't know the routes in Nairobi and New York, I knew exactly what I was doing. Now, we take it so much for granted that we don't even realize how powerful that is anymore. You know, why do I trust this little thing to get into a car? And people say, oh, it's the rating. Oh, surely the fact that somebody gets 4 stars doesn't, make me a safe, doesn't give me a safe ride, right? So I think the critical part is actually that when you do use an Uber or other digital technology, you have a smart contract. You agree as a driver, as a user, that you want to have an exchange together. I want to have a ride. The other person wants to offer services and make a little bit of money. And there is an application where we agree on the terms and conditions of that contract. That contract is digitalized. And once it is there, we cannot get away from it anymore. It will be executed. And that is one of the biggest trust enablers on the planet at the moment. And it's even more of a trust enabler in the developing world, where a lot of institutes aren't as strong as we have maybe in the more developing countries, exemptions there. So now think about when a pregnant woman in the slums of Nairobi will access healthcare services. All of the quality, all of the finances will come through supply side. So when she shows up at the healthcare facility, she cannot open an app and see what her journey for pregnancy, for example, is about. She just has to assume that people who meant well and wanted to give her a healthy pregnancy, financed through supply side, supported by a lot of the technical and great innovations that we heard the panelists talk about, and those are extremely important. But one of the critical parts is that it's completely intransparent for her to see what the quality of care is, what she is entitled to, where all the great minds in this room said we want to commit and we want to give her a safe delivery and a healthy baby. She doesn't know. She just has to assume for the best. And we know that ends up with a lot of inequality, people being left out, and people told that the staff is not there, the supplies are not there, and a lot of informal payments. One of the things that we've been doing as Farm Access is trying to change that with a system called MTIBA, which we developed together with Safaricom, where we were able to use that same digital technology where you can agree a digital contract between a patient and a healthcare provider, but importantly, between a patient and a healthcare provider and a payer, because we know that we need to reduce the out-of-pocket payments and we need to get all of this fragmented healthcare financing into a single wallet that can be triggered by an individual, so that when that pregnant woman accesses the healthcare facility, that all those entitlements and all those commitments of people walking around here at UNGA are triggered and are opened by her and not by a lot of well-meaning people in the healthcare sector. So I want to encourage the panelists, and I'd love to hear your thoughts. It seems that whenever we talk about healthcare, the finance people sit on this side of the room and the quality people sit on that side of the room. And just like my friend from WHO mentioned, you know, if you ask them to raise their hands, it's the government people, the private sector people, but the quality people and the medical people and the finance people, you have the same diversion. How do we get people in the same room so that we unite in fragmentation, including ourselves as partner organizations, as bilateral funders, put the patients at the center so that we allow them to trigger. And I really want to make a firm statement, because this is no longer about technology where we need to think about interoperability and all of that. If that system worked for me to use that same Uber app in Nairobi and New York, why can't we use the same technology to get it to work in Nairobi and in Lagos and make transparent healthcare? So we need to talk about quality, we need to talk about financing, and we need to talk about how do we get rid of this fragmentation, otherwise we don't get inclusiveness.
Thank you so much. I'd love for any of you to jump in on this, and I might even add to that this question of people even beyond the global health community who should be in the room. Because, for example, if there is no broadband access, that pregnant mother will not have the ability to access digital tools that could be at her fingertips. So any thoughts on this fragmentation problem? Feel free to jump in.
I think it's a really exciting idea, and I think exactly as you say, it puts it completely back in the hands of the woman or the patient, right? It's extraordinarily complex, right, as well, because, you know, funding for that health center is coming from a number of different places, and you've got, but that said, it's also not pretty complex to get the Uber app going and all the maps going. So it's absolutely something, and I'd love to hear more about the pilot you've started to think about how can we move in that kind of direction to put the health information and what you can expect and what do you need, both in terms of money and health systems, and is the obstetrician available when I'm in the taxi on my way there? Those kinds of fundamental questions that you need to have, those kinds of things. It takes a lot of data to get to that point, so just recognizing that, you know, health systems in many countries are not these smooth flowing, you know, very organized systems all the time. So thinking about how we can make that and bring some clarity out of the chaos would be, but it's, I think, a really, really interesting idea.
Bernardo?
Yes, I think there's a lot we can do. I mean, there are some sectors that we have seen working very well in terms of patient-centric or people-centric. If you think hospitality or the hotel industry, how it moved from a regulator saying this is a 5-star hotel to people saying this is a 3-star hotel, right?
Yeah.
But also we have the other side of the coin where without the regulation we've seen diseases being re-emerging because of the anti-vaccine movement, because basically when you say people and everybody can actually rate or express whatever they need to express, you might have also the other reverse effect or negative effect. So the key here to establish, to have a good balance between regulation and people-centric in a way that patients and people can rate, can have an input on those digital technologies, I mean, at every level. And I think the industry has some good case studies, some good examples of how you can transpond some of the things that work in some sectors to bring into the healthcare. And I think we need to do that. I mean, as as we go into the digital age where an AI device will give a decision on a diagnosis of a disease, how can we make sure that if that tool is providing a wrong decision, the impact is as minimum as possible? Because today, one doctor, a wrong decision has an impact to perhaps 10, 20, even 100. But a wrong decision by AI or a supported device might impact perhaps 1,000 times more than what a medical doctor can impact. So today, the regulatory body to regulate a device, at least from the WHO perspective, it takes, after all the clinical trials have happened, to just regulate a device, it takes 150 days.
Wow.
Now, a software or an algorithm might need an upgrade 5 times during 150 days. So how can we ensure that in these two worlds, we do not, I mean, we ensure the quality of delivery by having this constant and continuous improvement. So my hope, and from WHO perspective, one of the areas that we have in the department is really to look at this people-centered. In this global strategy of digital health, people are at the center of it. So one of the strategic objectives is exactly that. So there'll be a team that will be working with countries to make sure that in the national strategy, that element is at the center of the digital health strategy of the countries that work with us. Thank you.
Thanks for that. Did you want to jump in, Jan? I just want to make sure.
Yeah. Yes, I would like to jump on the example of Uber, because I'm tempted to go into an argument with you why Uber is so much different from healthcare. I don't want to do that.
I'm also saying it's not.
But I want to pick one word that you said during your argumentation, and that is trust. And that is a very important difference between Uber and the healthcare system. We published this year for the 4th time the Future Health Index. And that is a global survey where we try to tap into populations in 13 to 15 countries. We interviewed 3,000, or we sent a survey to 3,000 patients in every country and 300 healthcare professionals as a mean. And we try to poke into their ideas on digital solutions for healthcare. And although we see over the last 4 years that the appetite to use digital solutions in the healthcare world is increasing, there is still that trust that is not there where it is when you buy from Amazon, when you go on Google, when you go on FaceTime, or when you use Uber. And so far, most doctors and most patients feel very comfortable using digital solutions for workflow improvement, for planning of hospital outpatient visits. They feel much less comfortable when the digital solutions are really going into your personal data that will be shared all around without you having any control of that. If you use an Uber, you know that you will be rated as a customer. You know that the next Uber driver will put you on the 1st place or on the 10th place, probably based on the tip you gave him after your ride. That is definitely different from in healthcare. You cannot imagine that somebody would trust delivering all his data to a sort of black box, not knowing what will happen with it afterwards, and maybe being deprioritized in the healthcare system because of all kinds of data. So I start the argument, I will stop now, but trust is really different between what you do in your personal life and what you do in your healthcare-related life.
So for those of you who had questions we did not have time to get to for this panel, we'll be revisiting some of these themes and building on them in the next panel. So I will get to you in the next Q&A, I hope. Just raise your hand high and I'll look for you. Before we bring up our next round of panelists, please just join me in thanking these panelists for their time. Thank you. All right. So building on some of what we discussed in this last panel, and thank you to our panelists for those insights. Like I said, they've set us up for success in the second panel in terms of themes to build on. We're going to be talking about designing and implementing effective digital strategies. So as I bring our panelists up, I mentioned we do have a perspective from the Ministry of Health. So I'd like to begin with the Honorable Yeltsin Britanov, who's the Minister of Health from the Republic of Kazakhstan. There he is. Thanks so much for being here. And congratulations on the Astana Declaration, which we look forward to talking about. Please go ahead and take a seat. In fact, before I bring our other panelists up, I did want to start with a question for you, which is, I read that the Declaration of Alma-Ata was adopted at the International Conference on Primary Healthcare in Kazakhstan in 1978, and you were just a boy, but your parents, who were physicians, were in attendance, and you still remember that time. So now, flash forward, you are working to lead Kazakhstan to universal health coverage. And I'm curious if you can talk about specifically how digital health and technology are playing a role in that effort.
Well, thank you very much, especially for reminding me my childhood. Yeah, I remember that time, and that was actually one of the key stories when we were trying to move the next global conference on primary healthcare from Almaty to the new capital of Kazakhstan, to Astana. So we used that trick. I showed that photos of my parents staying there, and I said, we want to have the spirit of Almaty now in the new capital of Kazakhstan, in Astana. So now we have Astana Declaration on Primary Care. So yeah, that was a good story. Thank you. I am very pleased to be here, and of course for your question, it's very critical for us. Because for Kazakhstan, we are in front of the major transformation of our healthcare system. We are launching social health insurance from the January 1st, actually, 2020. So we've been discussing that for a while in our country, why and should we start with social health insurance, which is basically mandatory universal health insurance, and designing for a while, and there were a lot of questions about actually two maybe major questions. Are we ready? And the second was what kind of services we can afford in this new package. So for both of these issues, digitalization was a key issue. So when we talk about what type of services we want to include, what we can afford, actually we realized that the key issue actually what type of services we want to be included in the services, what type of services, health services you want to provide and you want to stimulate. And that's about actually managing not diseases, but managing the health. So of course we were using a lot of patients' data about what are services that people are paying for. So we found out that people are spending a lot of their out-of-pocket money for pharmaceutical agents and for visiting specialists. So using that data was critical to understand what we actually want to afford into packaging, into different packages of health services. And of course, the critical issue was how we can regulate that. So when you see that a lot of people are seeking for, endocrinologists, why is that? Because we found out that a lot of patients with diabetes are not actually registered. So we started to implement systems that will help us to register different critical diseases, non-communicable diseases like diabetes, hypertension, and in 1 year, the number of patients raised by 30% just because we digitalized the system. And the second issue was about are we ready? And that was a big discussion because everyone was talking about digitalization. And in fact, we found out that it's also a very important issue of interoperability because in Kazakhstan, any hospitals, they're allowed to buy their own hospital information system, basically. And we have about 50 products on the market, and maybe 10 of them are dominating. So a critical issue was to launch a special project called interoperability platform. in 2015. So now we have it, and now we are able to solve the main issue that all different systems in all different medical institutions can talk with each other and actually bring that information to the central platform where we can actually give a personal access, and each patients are also involved. So today we know who are our users. Today we know who are our providers based on that digital solution that we implemented.
Thanks so much for kicking us off. I'm really glad to have your perspective to set the stage for this discussion on what it really looks like to design an effective digital strategy. And I hope that we can get to in our conversation how outside partners can support that agenda in countries that are developing these strategies. So I want to go ahead and welcome up our other panelists. First, I'll call to the stage Dr. Stefan Germann, who's the CEO of the Botnar Foundation, which is a foundation based in Switzerland focused on leveraging technology to improve the lives of children in low and middle income countries with a big focus on health. I see back there Dr. Gitinji Gitahi, who's CEO of AMREF Health Africa and co-chair of the UHC 2030 Steering Committee. Thanks so much for being here. We also have Bic Lee, who is the business leader for ultrasound at Philips. So she can speak to the video you saw at the start of our discussion and how technologies can be a part of these effective digital strategies. And last but not least, Emmanuel Blin, who is the founder and CEO of Tech Care for All, which is focused on accelerating digital health outcomes in Africa and Asia. So a few themes came up in our earlier discussion that I mentioned I'd like to build on in this discussion, including how to prioritize, this interoperability challenge, and data governance. So I would just flag those three themes as themes I hope we can discuss in this panel. And then again, please keep questions in mind for our Q&A. So I'll actually start with Stefan down at the end of our panel there. You and I spoke a little bit this morning, and I learned more about your vision when it comes to digital health and UHC. So your foundation is supporting digital health in a number of ways. In fact, earlier, I sort of previewed this idea that AI can help address the health worker shortage and help deal with pain points in the healthcare system. So I'd love to just hear specifically how you think these advances in technology can help patients benefit and the work you're doing along those lines.
Yeah, thank you so much. And I think we have to acknowledge that what is happening at the moment in terms of AI and data science is what some say is rapidly moving into becoming a general purpose technology like electricity was when it was introduced in 1870. And imagine for a moment the world before electricity and after electricity. I mean, we don't think about this. Electricity is so embedded in everything that we engage with. AI and data science in the next 20 to 30 years will be much more transformative than what we have experienced at that point of time. And that has tremendous implication in terms of health and how we understand health. And actually, I borrow a statement that Philips a couple of years put in terms of their advertising, and they said that health is moving from the hospital room to the living room. So there's a total transformation taking place, but it takes quite a bit of time to actually embrace this. So if we take sort of three convergent technologies, and we can take them as circles, we have on one hand a massive explosion in terms of health data from what we talk about health in our social media, in terms of mental health issues, in terms of wearable, then clinical data, genomics, geospatial, environmental data. If you look at how much data was generated in the last 3-4 years in health, it kind of outpaces by a large amount what has been generated in all of human history in terms of health data before. So we have that one. Then in terms of algorithms and AI-associated technologies become rapidly more sophisticated. And then the third one is just sheer computing power, eventually getting into quantum computing. So these sort of three convergent technologies, they create, for the first time in human history, an unprecedented, deeper understanding on human well-being. And if we can leverage all of that, then, you know, we can really start to transform the way we do health. Today, we don't have really healthcare systems. We have disease treatment systems. But if we really start into moving into the space of sort of predictive data-driven issues from a preventative side, and a good example is Israel. Clalit is one of the largest health insurer there. For 20 years they have electronic medical data. And they use that in terms of really driving efficiencies and predictiveness. And the previous panel brought up the issue, and we recently did with sort of a coalition that is emerging to focus on digital transformation and campaigning for digital transformation for UHC 2030. We did a youth survey with more than 1,500 youth actually conducted by Devex in multiple geographies to really look at what young people think. Now, they don't have a problem in terms of sharing their data if they're guaranteed there's no discrimination happening. So the big sort of elephant in the room is really the topic that Bernardo brought up in the previous panel, and that's the health data governance issue. And we were able, together with the Wellcome Trust and the Children's Investment Fund, to have a high-level briefing on a forthcoming commission that is a joint commission between the Lancet and the Financial Times that's launched by the German Minister of Health on the 30th of October, that for 2 years will really have a deep dive in AI digital sort of transformation in the context of health data governance for UHC 2030. And I think if we change, that's my last point, that sort of mindset, we've started it on the wrong foot in terms of terminology. We talk about data mining. We talk about sort of data as the new oil. This is sort of a traditional commodity scarcity mindset, which is totally wrong. So we need to think data is easily, copied, stored at very little cost. We need to have an abundance mindset. We need to ensure that we have data flow. AI is incredibly data hungry, and we can only derive value if we really have the data flow across. Of course, we need to ensure all the protection and all these issues, but it is about how can we get data flow. And I fully agree. I do think we actually need some sort of international health data regulation under sort of an international framework that actually starts to tackle some of these issues. That's my last point. Thank you.
Thank you. And I look forward to that October 30th release of the findings in the Lancet. Katinji, I wanted to bring you into this. I saw you nodding your head when Stefan made the point we don't have healthcare systems, we have disease treatment systems. And ahead of the UN General Assembly, I was reading the Gates Foundation Goalkeepers Report that you're featured in, and you highlight 3 choices that governments can make to achieve better health results with limited budgets. And what you outline is spend a little more, spend on the right priorities, and spend more efficiently. So my question is, how do you connect these calls to action with digital health specifically?
Thank you very much. And I'll try and complicate your life by trying to simplify it.
Sure, let's see.
We've talked about interoperability, we've talked about governance, so let me add, and there's a third one as well, I can't remember, but I want to add a 4th dimension. I hope this is what works well. It's working well? Okay, good. So allow me to speak from an African perspective, that's what I know best, and also to highlight 2 things that when you're looking at this issue of digital health, you can look at it from a population health point of view or an individual health point of view. So allow me also to focus on population health dimension rather than individual health, because individual health is largely private sector driven, it's people making choices for themselves. And we know very well that when a technology works or innovation works for individuals, they adopt it. We've seen that in Kenya with mobile money. The government didn't have to get involved. They adopted it because it worked for them. Even the rural folk adopted it because it worked for them. So I'm focused on the more difficult side of population health. Now, the context is that within the population health infrastructure and the UHC we are talking about 70% of services are offered by government. I'm happy to see the governor of Isiolo here, who is also chairing in Kenya the governor's council or committee on health. So he's my boss, actually, in the health sector. So in the population health, if you're looking at 70% of the people seeking care from the public sector, and we're talking about scale, and then any of you who's listened to the conversation in the last few days about universal health coverage, it's moving away from universal health coverage to more specifically universal publicly funded health coverage. okay? Now, if you look at that now, from UHC to UPFHC, is there something like that? It means that if you're going to go to scale with digital health, because that's the challenge, there are challenges of interoperability is one of them, data governance, but the other one that actually we often leave on the table is about something called public procurement and Public Financial Management Act.
Yeah.
If I just look back to a few years, Governor Kuti was in court because he procured innovation. In government circles, procurement of innovation is called corruption because it's not regular. You're allowed in government to procure what people know. When you try to procure what people don't know, you're in trouble. And therefore, when we look at all this innovation that we are talking about here, the question, and I listened to WHO trying to discuss this governance because these are the challenges you're finding is, when you have good innovation, how does government, which I said provides 7% of the care, is a predominant population health leader, procure your innovation? That is the problem of scale. And we are not talking enough about public Financial Management Act. So the thing I would like to say is that as we go towards UHC, then we have to look at those three things that I was talking about. First is the money. How do you get the money? How do you use it? So governments know that if you use technology, you can actually leapfrog and you can get cheaper services. You can increase efficiency. So that's not a debate. The next question is, what technologies do you need to procure? Then we now have to tie back this conversation with what we call the health benefits package, or the benefits package of the AHC in each country, which then brings you to the question of how do you decide which technology the government requires? Because you can't just buy anything because it's new, which then brings you finally to what we call health technologies assessment. Now, within the health technologies assessment, each government is doing a health technologies assessment to decide what package to offer and what technologies are required to offer that package. So we must engage with the health benefits package, health technology assessment in the countries, and the Public Financial Management Act for us to move to scale.
Thank you. That's really powerfully stated. And earlier we were talking about interoperability, data governance, and prioritization. So I think your point gets exactly to what that looks like, and the public procurement point is really valuable. So thank you for that. Emmanuel, I want to bring you into this. And earlier we were talking about examples we can learn from, approaches that have been taken that have worked. That kind of defy the odds of the pilotitis, right, in digital health. So can you share with us, in your own work to address unmet healthcare needs in Asia and Africa, what is a story or two you would zoom in on that offers some lessons for today in terms of designing effective digital health strategies?
Yeah, so thank you. So first of all, I think, you know, in the technology world in general, and in digital health specifically, I think we are all facing what I call a new virus, which is like solution is looking for a problem.
Yeah.
So, and that's why nothing gets to scale. That's the fundamental reason. So a lot of solutions are deployed, but they are not sustainable because the problem of the objective they want to deliver is not well defined. Okay, so I will give you two examples of that. So one is in primary care, which I believe should be the priority of low and middle income countries in terms of focusing investments, focusing improvements. So, and we all know that in sub-Saharan Africa alone, we need 2 million more CHWs, we need 1 million more doctors. It will not happen. It just will not happen by 2030. So, when it comes to improving primary care, what do you want to achieve? What are the objectives you are going after? You know, is it about diagnosing better? Is it about decreasing the number of referrals that should not happen? Is it about accelerating the number of referrals that should happen faster? Is it about better connecting CHWs with doctors? Is it about better allocating secondary and tertiary care resources? So what are the objectives you are truly looking for? You know? And once it's well defined, then we all know that digital health technologies will play a significant role in deploying a solution. So one example is that we are currently working with one government in West Africa on, and it covers all these issues somehow together on, they have designed a very nice e-health strategy within the new ITU framework. And now the question is, okay, but now that we have a strategy, how do we implement it? And so what they have decided working together with us is around, it's really about, at the end of the day, we need, for each and every citizen in that country, we need one electronic patient file. When we talk about interoperability, when we talk about things should talk to each other, that's what we are talking about. So at the country level, a decision needs to be made that they want to have for each and every citizen one electronic patient file. And every front end, whether it's an app, an electronic medical system, connected diagnostics, whatever tools are used to capture data at the patient level should be able to feed and be fed by this electronic patient file. That's interoperability in action. But why do they want to do that? They want to do that with one objective, it's to improve health outcomes at the primary care level, with very well-defined targets for improving health outcomes. And once you have that, then we know what to do. We know what kind of connected diagnostics we need to deploy at the point of care, how we should connect them to a back-end system that will create this unique patient file, how we should connect them to the secondary care EMR and EHR systems that are used in hospitals. Then we know how to train the CHWs. We know how to partner with NGOs who have frontline workers, government dispensaries where they have frontline workers. On what should we train them? We know how to measure success because it's about improving outcomes in primary care diseases, specifically. How do you reduce amputations in type 2 diabetes? Because you are able to diagnose, follow, treat better at the primary care level. How do you avoid, how many kilometers of useless travel do you avoid? So the mandate there, just to finish, the mandate there is, I think, it's a call for us, all of us, to actually look at projects in terms of outcomes, not in terms of inputs. And most of the money today goes to initiatives where success is measured by did we do what we paid for? Right. And most of the projects are not funded on the basis of does it improve outcomes of patients and does it create a more cost-effective healthcare system?
I'd love to hear when we move into conversation how we make that shift toward judging success based on outcomes. So, Bic, we all got to see earlier a little glimpse into this ultrasound technology in Rwanda, and I'm sure you'd be the first to say it's not just about the technology, but the enabling environment. Of course, on our first panel, we were focused on the enabling environment. What are the challenges? How do we work through those challenges? Now we're talking about designing effective digital health strategies. So when it comes to your work in ultrasound, what I'd love to hear is how does the digital health strategy of Philips and the digital health strategy of country partners like Rwanda come together?
Sure, I could spend all day probably talking about the product, so we'll avoid that for a moment. But yeah, I think part of the design conversation really is around, yes, you need to be able to design and develop affordable tools. So that's a piece of it. There are telehealth platforms, there are education platforms that are beyond the tool, that are critically important, and I'll use the example of this portable ultrasound system with a how are we doing? Okay. So fundamentally, if you look at what we're trying to accomplish, it's the connection of people, digital data, and technology. And if you use the video as the example, right, this Philips Lumify with Reacts platform is really an affordable tool that has the ability to share digital data where and when that information is needed. So it's really a way to connect through a telehealth platform, connect an expert user, a physician that may be in a different location, to where the patient might be. Now, that could be moving information from one department to another, or it could be moving information from, a physician in Philadelphia to a midwife in Rwanda. So these tools can be quite powerful. Now, I think, some of these digital strategies can be quite limited because it's not just about these tools, right? So the underlying infrastructure that we've spent the morning talking through is really critically important. So, of course, we talk about sustainability in terms of food, clean water, sustainable energy. But I think we haven't really talked also about education and, fundamentally the education of women as a critical role in that as well. And so I think the partnership between the private sector and governments, you can start imagining wonderful ideas that can emerge, ideas in terms of co-creation innovations that are specific for the local market. You can imagine financial solutions that are really going to be able to help sustain these. And so the example with Rwanda is one great one, because we have a shared objective. We have the enabling technologies. Yes, we're willing to pilot as well. But now we're starting to talk about scale. And I think it comes back to this conversation of alignment of goals. So I'll just use one that Irene had talked about, which is mother and child care. So we have a project in Indonesia using the cell phone, of course, to connect information between, again, where that mother might be, potentially with a midwife, and where a physician might be. Now we're taking, ultrasound information and adding to that and scaling that to the Philippines, to Kenya, to South Africa. So this is just a wonderful example of how that partnership with governments is really vital. And of course, I'm excited to be here these next couple of days to really explore that with government agencies around the world.
Thanks so much. And before we move into Q&A with the audience, any just quick reactions from panelists? I saw some of you nodding, taking notes. Our task in this panel is to talk about not just designing, but implementing effective digital health strategies, which I think it's sometimes that implementation part where challenges can arise even more so than in the design. Any quick reactions to what your fellow panelists said?
Just one comment maybe on AI. And again, it's in that context of solution is looking for a problem. So I'm coming from the drug industry. Mm-hmm. There are billions of dollars which are spent today on precision medicine in oncology. Mm-hmm. Because the problem people want to address is most of the oncology chemotherapy treatments are not effective. But they are in general, but very effective in certain categories of patients. So then AI, big data is there to enable precision medicine to happen. So there is a real problem to solve. And because there is a real problem to solve, there is a lot of innovation, there is a lot of money, a lot of progress, and a lot of improvement actually happening in terms of patient care. So in our world, I see an immense value of AI to address the problem of, on the other side of the CHWs, there are no doctors. They just don't have time to look at remote diagnostic reports, to do video consultation when the internet capacity is there. They just don't have the time to do that. And at the point of care level, in front of the patient, the CHWs, they don't have time to capture data. Neither. To record data in the smartphone or whatever. So here, I think the combination of connected diagnostics tools at the point of care, where data is ubiquitously captured, without CHWs having to spend time on them. And second, once an electronic record is created at the point of care, the ability to use decision support tools, which follow well-accepted international guidelines. HbA1c levels define type 2 diabetes. I mean, you don't need a doctor to judge whether you are above or below some numbers. Hypertension is hypertension. It's well defined globally. So at the primary care level, there are things where you could implement decision support tools much more easily. In some diseases, you could actually establish a diagnostics without the intervention of a doctor I'm not saying in cancer or in rheumatoid arthritis or in complex diseases, but at the primary care level, there is a lot of value in trying to automating some diagnostics, leveraging connected diagnostics data. So I would really encourage the community to look at that as, I think, a very significant priority if we want realistically to improve outcomes in low and middle income countries in a context where we will not have, in the next 10 years, we will not have the number of CFWs and the number of doctors we need.
Yeah. Okay.
Either of you, go ahead. There we go.
Just very quickly to highlight two resources critical. There is the 9 principles of digital development, and if you're not aware of it, and if your organization hasn't kind of endorsed them, that is really the 9 building blocks that really will help in terms of strategies to get at scale, in terms of interoperability, etc. The second one, just as a reference, USAID, together with the Bill and Melinda Gates, did recently a very good sort of scan around AI and global health issues that has a nice categorization in terms of different categories, and it's a really good resource that's worth looking at.
Good.
Go ahead.
Very, very quick. I've seen too many innovations that just come and fail or come and go. But actually, the era, there's no design error. It's a good innovation, and I've seen innovations that have won awards but don't get anywhere. And the issue that we need to really think about is innovation and digital health, is digital health need-led or innovation-led?
Yeah.
That's critical, because we tend to have digital health that's innovation-led. This is a great innovation. We are going to take it to this country. But what's the need of that country? Yesterday, I attended the PMNCH breakfast, and there was a study of 1.2 million women across Africa, I think there were many of them from Asia as well. And they were asked, what do you really need for better productive health? And they all said water, sanitation, and hygiene. Secondly, compassionate care. So is digital health need-led or innovation-led? It must be need-led. So the first thing to say is start bottom-up, offline first. Because I think too much innovation is led by technology. And I know we're talking about digital health here, but we have to make digital health the enabler of a solution that we are working with Philips, we are working with PharmAccess, and we are using technology on many areas. Part of our challenges have actually been adoption and diffusion to government. You'll know that we've tried MTBA to move forward, but they can't, because how does the government procure it? We have LEAP for training community health workers. We've been working with the government as a partnership for the last several years. They just tell us, oh, this is a good system, please keep doing it. They'll never adopt it because of procurement issues. We have now Damusasa for making sure that blood is available, but the government will just watch it and clap, and they'll come for your launch, but they'll never adopt it. So the partnership needs to be offline first, need identified, bottom up, and needs to be need-led, not innovation-led, and finally must be integrated into the public procurement process for it to be successful.
I love that point. Quickly, before we go to questions, I have private sector perspective here and a Ministry of Health perspective here. How do we move from innovation-led to need-led?
I'll start with the private sector example. Couldn't agree with you more, but I think we have to be super careful around, we cannot assume that the need in Kenya is the same as the need in South Africa and the same as the need in Indonesia, even if they're all low resource settings. Absolutely. And that, I think, is one of the key shifts that have to be made. Now, the challenge that we have to overcome is, okay, well, there's 200 different needs, so how do you scale then these products and these solutions? And I think tools like AI, as an example, can be used. So where those needs are common, automate them, simplify them, right? As I lovingly call it, stupid simple. And when we start thinking about how do we create the flexibility when those needs differ from country to country. So that fundamentally, I think, is one of the mind shifts that we're making within Philips and hopefully within the partnerships that we have.
Great. And in Kazakhstan, or with your conversations with other ministers of health, how do you make that shift? Again, I love that framing of making sure we go toward need-led.
First of all, we all understand that there are different stakeholders or participants in healthcare system, not only doctors and patients. There are a lot of people and agencies are involved. So the first thing, you have to build the system where you can hear from all of them. So, for example, in Kazakhstan, we hardly involve patients' organizations, like for diabetes, hepatitis, and other patient organizations, so we can hear what are their needs. And in fact, it's very useful. It's not only about, of course, what kind of services or medicines they will need, but what kind of the relations between health system and patients they're seeking for. Of course, very important to hear what are healthcare providers, physicians, they will need. Of course, when you make them, force them to go digital in short period of time, that's challenging, of course. We've been trying to switch from paper format, and still on the way actually, to digital format for a while. So it's also important to hear what would be the best solution for healthcare providers. On the technical level, of course, we learned that sometimes you need time to make a solution. So it's not like you bring the task to the technical people and say, you know, I want this next morning. And at the beginning, it was very difficult because medical people will always putting tasks to technical people and not giving the time to actually implement, to assess and make very careful implementation. And on the government level, for Kazakhstan, I think the solution was it was a highest political support from the head of state, from the head of the government. We have, like in WHO, we have Chief Information Officer in the government. We have special ministry and who are responsible to bringing all ministries and agencies together. We have a specially assigned vice minister on digitalization in healthcare. And we have some chief information officers in many other agencies. So they come together and they, you know, solve the solution how different systems in different agencies need to talk with each other. So, and that's very important information because it's a huge amount of information back there, and you never know. Well, if you look at the, for example, health information in health system, information about patients, but when you look about labor and social defense, there's another pool of information and not really integrated. The same with educational system. So one of the critical tasks on the level of the states, on the governments, is to also to involve all stakeholders, because in many cases, in the reality, you cannot design it upfront. Yeah. So you come with this and you already realize that it's too late sometimes. So you need time and you need team efforts to bring that solutions. Thank you.
Thank you. As we open it up to audience Q&A, and I do hope to bring in any questions you might have had, building on, I suppose, both panels today, but hopefully directing it to these panelists here on stage. Are there any Ministry of Health perspectives we can draw on? I know we got a sense of who's in the room earlier with a show of hands, but I would love to bring in another government or Ministry of Health perspective for a reflection or a question. And if not, no pressure. Right there. Did you want to say something? And could you introduce yourself as well?
Thank you. My name is, maybe I stand up?
Sure.
My name is Dr. Kuti. I'm governor for one of the 47 counties in Kenya. And I'm also the chair of the Health Committee of the Council of Governors. As I was listening, I realized, of course, the issue of procurement is a major barrier. But I think also another aspect to this is the fact that like a country like Kenya that is moving out from aid to trade. We're moving from now the former relationship that we had with the developed world is one of aid, but now we are moving, because of our economic status, we're moving to trade. But I don't think the plug-in between trade is now as effective, because all along, NGOs have a way of connecting with government. Donors have a way of connecting with government. I don't think the private sector is having a good plug-in with government. because the public-private partnerships are very weak, and the legal frameworks are not effective in creating a public-private partnerships. And most of these innovations are private, and they need to, therefore, a partnership is required between the private and the government. And I think governments need to work now to this new arena of plugging in with private easily and be able to move quickly, because it takes a lot of time, and effecting programs becomes very difficult. Thank you.
Thank you.
I think I mean, the way I see it, we have operations in India, in Kenya, and in Senegal to cover West and East Africa. So I think the situation is in low-income countries is very, very different than the situation in lower, middle, and middle-income countries. So just to give you one example, in India, the private sector, the healthcare delivery private sector in India is thriving, modernizing, innovating at a very high speed. So the two other parts of the healthcare system, the government part, in terms of healthcare delivery, government hospitals, dispensaries, and the NGO part, the faith-based or non-faith-based NGO part, these two parts of healthcare are now struggling to cope with the speed at which the private sector is innovating. And the result of that is that historically, for example, the faith-based delivery in India was sustainable because in the big cities, the middle class was going to their hospitals. And now the middle class start to go to private hospitals and not to go to these hospitals anymore. Because the private hospitals are modernizing quickly. They offer a patient-centered, patient-centric service with a lot of innovative, digitally based services, which is not the case in government hospitals, not the case in faith-based hospitals. So those faith-based hospitals are like struggling. We work for the biggest one in the world, 21 million patients, bigger than Senegal. They are really struggling. So their problem is, how do we modernize? How do we digitalize our dispensaries? How do we connect them to our hospitals in cities fast enough so that, again, we can be attractive for patients in the big cities to make sure we can continue to reach the unreached and to treat the poor in rural areas. And so we are working with them on that very fundamental problem. But I see the same kind of happening in Kenya. I see the same happening in other middle-income countries or lower middle-income countries. And I think it is interrogating, and it is interrogating public procurement practices. It is interrogating the speed at which governments and in lower middle-income countries, their donors are actually enabling them to catch up with the way the private sector is innovating.
Did others want to jump in on that question? Go ahead.
Yeah, I think one of the very critical elements that you highlighted in your question is that I do think from a human capacity point of view, we don't have enough people who really understand sort of tri-sector collaboration, who really understands what are the drivers of accountability of a government versus a civil society actor versus a private sector actor. And they're very different accountability, they're different languages, different concepts, and we simply do not have enough people in government or in civil society or in business to really able to broker this in a very meaningful way. And I think if we really want to move forward, and Michael Porter in a recent Harvard Business Review looked at sort of the SDGs and sort of the role of private sector, and it's quite a damning sort of report. I mean, you have a few good sort of corporate citizens who really take that beyond the corporate social responsibility to really transforming the business in a new way. But for most business leaders, it has not dawned that the way we have done business the last 50, 60 years is not going to be the way business will happen in the next 50 years. And there needs to be, on all fronts. So it's not about finger pointing to private sector or civil society or government. It's just, unless we sort of, and it's sad to say, so the Singapore Management University recently launched in 2015 an executive master's in tri-sector collaboration. They had to close it after 4 years. They didn't have enough students. Wow. And I think that just shows that the kind of understanding that the world in terms of how we address complex issues that we are facing can only do it if sectors start to very effectively collaborate with each other, and that it needs a new skill set of new leadership.
Yeah, I think that the challenge is that we are trying to build the future on a system that was built for the past. And this is really the challenge. The things we are talking about the Public Procurement Act, it was built for the past. How does it look in the future? Right now, in many of the countries where Governor Kuti is talking about, we have the PPP Act. In some countries, not many countries even have a public-private partnership act. But now, if you have an innovation, because innovation is not kind of publicly advertised for tender, because it's your innovation, when you have that and you want to take it to government, you have to go through a process called a privately initiated partnership. That requires approval by cabinet. Can you imagine what it takes for you to take something to cabinet? It needs an investment of $50,000 to show feasibility study. It's impossible. So I think what we are being called upon to do as an ecosystem is, number one, to start innovating within existing ecosystems fast so that government can learn. We have what we call innovating residents within AMREF. So we see innovators, we bring them in, and we tell them, you are an employee of AMREF, but not on payroll, but please work within the ecosystem. Work on the malaria project funded by Global Fund, work on this, other, because then you learn, how do the systems work? So we embed innovators within ourselves. That's number one. Number two, as an industry, we have to think about how to create the platform for the future now. So this is how we have to engage with other private sector, including pharma, in assisting governments in capacity to engage private sector, helping to create the necessary institutions for that, and we have to engage actively, and we can bring other industries that are beyond digital health to work together with them.
Yeah. Quickly, yeah.
I just want to reinforce that, just 1 minute. The availability of these new technologies is creating immense new opportunities for big corporations. For big pharma, for medtech, I'm very happy to see how Philips is engaged in that space, Becton as well, others. In pharma, there are a few ahead of the curve leaders who are really taking seriously the new opportunities that digital health represent for their development in sub-Saharan Africa and in other LMICs countries, opposite to the past. So I see telecom companies interested in, leveraging some of these digital health companies to actually become more commercially attractive for their customers. I see the banking industry. We have worked for a bank in West Africa. I see the banking industry starting to think about, should we offer remote medical services to our customers as a way to attract them and keep them, opposite to having them going to another bank. So there are lots of corporate players who are starting to think about, okay, how could these new digital technologies really help us do more business in sub-Saharan Africa and in LMICs, in our business. And I think that's one of the drivers of actually creating more sustainable ecosystems for digital health in LMICs. That's a driver for startups to scale up faster in a context where public procurement is complex and long. So I see that as a very big opportunity that we should all embrace.
I want to make sure we only have a few minutes left, and I know we all have very busy weeks here. I want to let everyone get to their events on time. I do see a hand back here. I'll ask Jamie Nishi to go ahead and ask a question, but we have to make an answer very quick. So if you could possibly direct it to one panelist, I don't know if that's possible, or we'll see who's quick enough to jump in first.
Well, just picking up on the last point, Jamie Nishi with the Global Health Technologies Coalition, I'm glad to see the connection made between digital health and drugs, vaccines, diagnostics, life sciences, and helping to make that linkage. So the question very briefly is, how can there be a better dialogue there in terms of leveraging digital health to help to inform where the interventions are missing or where interventions need to be adapted to actually tackle some of these global challenges? And then even at a macro level with the global fora, how can that help to reset some of the prioritization?
Yeah. So I don't have the answer to the question in a holistic way, but I can give you two examples, maybe one for time reasons. So we work for a company which has a drug which does $6 billion US worldwide, $5 million US in sub-Saharan Africa, where in volumes 35% of their patients are, okay? So the management is thinking about, okay, how do we reach the unreached? how do we enable people who never had access to our drug for a lot of reasons, including affordability, including pricing, but not only. Let's go back to the primary care discussions we had earlier. So how do we enable the unreached to have access to our products? We are in a dominant position, so whenever we increase the size of the market by 10, we capture 5. So they have a business interest in developing the size of the market. From our perspective, it means providing access to care to people who don't have access to care and who have a disease that could be treated with our drug. So we are helping them designing and implementing a diagnostic strategy. How do we leverage CHWs, NGOs, governments, partner with them to increase diagnostic rates? How do we channel those patients into the right referral centers where they can confirm diagnosing, initiate treatment? How do we follow up patients? We don't lose them, we make them adherent as much as we can, compliant to treatment, because that's a massive problem everywhere. And technology exists now to do that in a digital way. And for them, it means they know what's happening, they know how many patients they have, they know their characteristics, they can follow them, they can build online payment solutions for them, they can build innovative, affordable packages that are available online, working together with banks and insurance companies. They can track their products. Supply chain is very different now with digital.
Let me give a very simple answer to you.
Very quickly.
That actually the patient who needs biopharmaceuticals is the same one who needs digital health. Just sit around the same table. We have the digital coalition forming. We have IFPMA. We have Access Accelerated. The community needs to get together and look at the patient. Patient-centeredness is really the critical bit. Forget about all this technology, all the innovation, all the, the high-level AI, everything. Just get around one patient, and you'll find it will be much easier.
Thank you for bringing us back to patient-centeredness. I'm glad we're closing with that. I know there are more questions. What I'll encourage you to do is to continue the conversation with our panelists as they leave the stage in just a moment. But we are at time, so really quickly, I wanted to close with a quote that someone shared with me yesterday that I think is worth keeping in mind. So this was Naveen Rao, Senior Vice President for Health at the Rockefeller Foundation, in a story coming out in Devex tomorrow. And he mentioned the words of Mahmoud Fatala, who was a former president of the International Federation of Obstetricians and Gynecologists. He said, back in 2006, women are not dying because of untreatable diseases. They are dying because societies have yet to make the decision that their lives are worth saving. And I just think from 2006 to 2019, all of these new tools at our disposal, and I think it comes back to that same question. We have all decided that, of course, these lives are worth saving, and yet that's why we're in this room, and yet these technologies are just not available in these places. And it's not for lack of technology, it's for everything we discussed today. The challenges with the enabling environment, the challenges with digital strategies. So I hope each of you walk away with at least one insight that you can act on, and that you can think of one thing you'll do differently as a result of this conversation, even if it's finding a panelist to talk to, ask your question to, or finding someone next to you to maybe form a collaboration with. So with that, I want to thank my Devex colleagues for putting this event together. Thank you to Philips for supporting this conversation. Thank you to all of you for your time during this busy week, and please join me in thanking our panelists.